A lot of objectives, so in 50 minutes, I guess. So we'll get as far as we can. So really it's the kind of the continuum between subclinical to clinical in terms of anxiety and depression, and a little bit of the evidence-based research on that. There's a lot of it, so I tried to pick some of the key elements. And then a little bit about the self-awareness and transference, not so much, but self-awareness and the precipitating factors, those kinds of things. And then at the end, I'm going to throw in a little bit of the wellness model, which is, you may not have heard of it in the way that I'm going to present it. It's a counseling-based wellness model that we use in working with clients, and then also I do research with that model. It's got a lot of good points that I think you can use just for yourself and then for those that you work with. This may look strange to have an athletic identity piece on there, but hopefully I'll connect the dots here. So one of the first things to know when you're talking about these things is just that self-awareness, because we talk about burnout and we talk about depression and those kinds of things later in the presentation. But if we're not, burnout particularly, really having an understanding of where you are in terms of kind of the burnout symptomology is good, but that requires obviously reflection and self-awareness. So usually when I talk about these kind of things, I talk about athletic identity because I work with college athletes. But there's a thing called athletic identity, and what I talk about with the athletes is how much of your own sense of self is wrapped up in you being an athlete. And that does have implications for us today as mental health professionals, healthcare professionals, how much of your identity is wrapped up in being a nurse, being a physician, or anywhere along the lines. And when you look at the burnout research, it's pretty clear that we tend to give a lot to people and we sometimes forget about ourselves and our own well-being. So that's just kind of an entry point into paying attention to ourselves. The depression versus the blues, those laypersons will often talk about, will just kind of equate having the blues with having clinical depression. And we know in healthcare that's a pretty big leap, kind of talk about a general term to an actual diagnosable syndrome. So we know that in our society, if I could overgeneralize for a second, we tend to use emotional descriptors for depression, anxiety, those kinds of things. But there's a whole list of elements that we'll get to symptomology-wise. So if you're going to ask yourself just initially, am I actually depressed, or am I working with somebody, or do I have a family member who's actually depressed or has bipolar, what exactly does that mean? Well, hopefully when you walk out, you'll feel really good about that. But just generally, you have to take just contextually initially. What's going on? What are the situations? Is somebody in a new environment? Is somebody in an environment that they've been in for a long time, but there's been some kind of qualitative change in it? So there's all kinds of contextual factors to think about. From a diagnostic standpoint, duration and severity are always big elements, and particularly when you're working with folks, or even ask yourself, how long has this been going on? And we know in healthcare that duration and severity have a lot of indicators, but duration specifically from a diagnostic standpoint really can give you, really helps you kind of differentially diagnose, for lack of a better way of saying it. So we'll get to that. Anytime you're talking about a depression, anxiety, or any other mental illness, of course, you have to rule out substance use and medical issues. And then one thing that I've found over the years that really does play a much bigger role than maybe my multicultural class would have taught me are cultural factors. Now, you might think I should have paid better attention in that, but if you don't find yourself in different kind of cultural elements, it's easy to miss them after a while. For example, I used to work in South Carolina in a very rural mental health center in South Carolina. And you see here with the Latino culture, they might equate depression or something with nerves. Well, the folks that I worked with also equated everything with nerves. When I would say, what brought you in today, they would say almost really like 30, 40, higher than that. They would say, my nerves are bad. And as a beginning counselor, that meant to me, where I grew up, that meant anxiety. But to them, it meant everything from childhood sexual abuse to anxiety to depression to substance. It meant absolutely everything. So my skills as a diagnostician got a lot better once I realized that they were using my nerves are bad for absolutely everything. So just be considerate of what the cultural elements are. In some of the Eastern cultures, anxiety, depression might manifest as more physical symptomology. They might talk about pain or discomfort or upset stomachs a lot more than kind of in the Western culture. So if we're kind of going on that continuum from subclinical to clinical, just by a quick show of hands, how many of you have ever heard of an adjustment disorder from a mental health standpoint? Several of you have. Okay, good. I always like to start with this because when people talk about depression symptomology or anxiety, it's easy to jump to major depressive disorder or some other kind of big diagnosis that people have heard of. Adjustment disorder is essentially a normal human reaction to a stressor, an identifiable stressor. And one of the things to keep in mind with an adjustment disorder is the time frame involved. And you can go back up to 3 months of trying to identify maybe what that qualitative change was in that person's life. And in my experience, people will talk about maybe a 2-3 week time frame, but to really go back 2 or 3 months, people have they may have not forgotten about the stressor, clearly, but they may have really not equating. It could be that long in terms of an issue that's been going on that I've been experiencing this. And clinicians, a lot of times, especially when we train new clinicians, they forget entirely to go back that far. Because, well, it's been 3 months ago. How could that possibly still be part of the issue? But it certainly can be. And so, again, it's not going to rise to the level of major depression, but there are a lot of indicators that people can kind of conflate an adjustment disorder with a major depressive disorder or something like that. So one of the things to note here is the timeline, and it has to be, like if somebody experienced a divorce, that's kind of an extreme. I just work with a lot of college students, right? The first time they've been at UNO, maybe they moved to a different city, big city, those kinds of things. Pretty normal stressor for a lot of people. And they're having a reaction for about a month or two that we can't identify anything else that might be a bigger issue from a diagnostic standpoint, but that's certainly a pretty normal response to move to a new college environment. You've got the social stressors, the academic stressors, et cetera, et cetera. So it has to be a qualitative change, though. You've noticed that there's been a shift. They may not be studying as much. They're real good students. They can't get up in the morning, all these kind of indicators. But I do call attention to the specifiers a little bit, because the specifiers, you can have an adjustment disorder, and it could present obviously differently for different people. So whereas some people might have more depressive symptomology, others might have more anxiety, it doesn't mean that it's a clinical level, but it's certainly you might see those kinds of things. So that's adjustment disorder in a nutshell. So the DSM-5, which is the newer version of the diagnostic manual, has changed. It used to be mood disorders, and you'd have depression, depressive mood disorders, and then bipolar would all be within that. So now they've switched it up. Probably not the most exciting thing to you, but it does make a difference in terms of trying to find things in the DSM. So a lot of information on here. Again, I won't go over all of it. A couple things, though. The triad of depression, that's Beck's triad of depression. So when you're listening to people that might be struggling with depression, what am I supposed to listen for if somebody's depressed? Well, Beck's triad gives you a sense of that. If they're talking about, everything's bad, I'm bad, the world's bad, I've got no future, you hear those kinds of elements, it doesn't mean they're depressed, don't get me wrong, but those are kind of narratives that you hear kind of consistently from people that might be struggling with depression at the time. I would also point out, if somebody is struggling with depression, your healthcare professionals, it's hard to be around people that are suffering for all the time. And people that are depressed, family members often get frustrated with them. It's kind of depressing to be around depressed people, so to speak. And so just something to kind of monitor yourself. If somebody is struggling with that, to monitor yourself about how are you experiencing being with that person that's struggling. Okay, just some quick facts. 1 in 5 people over the course of their lives will experience a major depressive disorder or bipolar. The prognosis is good for that, which is nice to hear, even though that's a pretty large number of people that might experience that over the course of their lives. If somebody, just diagnostically, if somebody experiences a major depressive episode, for one time in their life, that does not mean they'll ever experience another major depressive episode. It may have been very situational. If somebody is diagnosed with bipolar disorder, that changes that dynamic a little bit, where that diagnosis would stay. That would be seen as a persistent mental illness. And of course, that changes all the treatment strategies and things like that. But it's easy to mix those up, that they both could happen once. Only a major depressive disorder would not be diagnosed again. So if it didn't happen. So anytime you're talking to somebody with concerns about do they have a depression or anxiety, you're of course taking a biopsychosocial. You want to get as much, is there a history of that in their family? That's always good information to have. But also the social and the psychological elements as much as you can. So talking to healthcare professionals, I don't feel the need to go into a deep dive on assessment, but just in terms of not forgetting about even nuances that might have changed in their life, in terms of trying to figure out what might be a trigger that might not seem, and it's also like, what's a crisis? Well, a crisis is whatever somebody determines, but what's a trigger to depression or anxiety? It's whatever that person determines is too. So don't be afraid to get into the weeds a little bit on trying to figure out what the distinction might be. The lethality potential, of course, if you're going to talk about depression and bipolar, and particularly, you have to talk about lethality, potential for lethality. So I put 15% with major depressive disorder die by suicide. I found that, but then I forgot where I found it. So that seems really high compared to what I remember being in the DSM, about 4-6% or something like that. Nevertheless, if you're assessing somebody for depression, even if it doesn't seem that severe to you, make sure that you ask about any concerns that they have about harming themselves, having suicidal ideation, anything like that. Just don't let that pass you by at any point, because it's very elevated from a percentage if people are suffering with depression and bipolar. So before I jump into major depression, which I'm kind of hoping is the one everybody just is very excited to hear about, because it's the one people talk about, but if you look at the depressive disorders, there's a list of them. And so just quickly through these, the disruptive mood dysregulation disorder, it's a mouthful, but I'm really glad to see this in the new DSM-5. And if you'll note just a couple things, it's diagnosable from 6 to 18 years of age. Now, one of the benefits of that to me when I was working with adolescents was I worked in a private hospital, and they would come in, and and this was 15 years ago, but they would almost inevitably leave with a bipolar diagnosis all the time. That just seemed to be the thing at the time. There was no disruptive mood dysregulation. But if you look at what that is, temper outburst, and we're talking about 6 to 18-year-olds, temper outburst, and then in between those, that still elevated kind of irritability and things like that. Well, that used to be conceptualized a lot, at least in my experience, as kind of bipolar irritability, prodromal, that kind of stuff, even for kids that young. So that's kind of what that diagnosis gives a little different way of taking a look at how that behavior might be. The persistent depressive disorder used to be called dysthymia. So you've probably heard dysthymia. That's the new version of that. One of the reasons that they changed that was because dysthymia, and I'm completely guilty of this as a clinician, of kind of minimizing, oh, it's just dysthymia, right? It's not major depression, so ergo, maybe it's not as important or as severe. Well, part of that was we need, clearly it is important. Clearly we don't want to minimize that. So they changed that. It's a lower grade version. It can be kind of tricky to diagnose because it can be up to 2 years, but you can have periods where it remits for a month or two, and then you could have periods where it actually elevates into a major depressive disorder again. So if you're diagnosing somebody or working with somebody that's talking about mood, don't be afraid to kind of ask them very specific, do they meet the criteria, but also the timeline. Because if you can get the timeline, give you a really good sense of what they're going through. The premenstrual dysphoric disorder, that's also new to the DSM-5, and that is the depressive symptomology, irritability, and tension before menstruation, and then eases after menses begins. So it's not premenstrual syndrome. It's a different diagnosable category that's new to the DSM. So just to know that there's a variety of depressive disorders, not just major depression, which everybody kind of goes to. So here is my obnoxiously content-heavy slide. And I purposely did that for a couple reasons, because if you are totally bored with this, this is good information that you can go look up later, because it's got everything you need diagnostically on it. But one of the things that happens when people talk about depression, laypersons talk about it, everything's major depression. Well, we know everything's not major depression, but how do you actually diagnose a major depressive disorder? Well, for better or worse, I'm going to take you through this real quick. You may know this, but just category A, even within category A, you've got to have 5 of these 9 symptoms. You have to have at least depressed mood or a loss of interest or pleasure. Now, the depressed mood often kind of stands out to people, the emotional reaction to it. You know, they're sad, they're down, those kinds of things. But it's also equally important to pay attention to, have they changed their patterns at all? Are they somebody that works out a lot? Are they somebody that reads a lot, et cetera, et cetera? And all of a sudden, they're not doing those kinds of things. So if you think about the stigma associated with depression, somebody might not want to tell you, I'm depressed, but you might notice other things that lead you to ask them those kinds of questions. So that lack of interest is one. Then you've got a specific timeline of 2 weeks. So they've got to have all of those within that 2-week timeline. If you think back to adjustment disorder, that's up to 3 months that you can be considering that. So they may be initially diagnosed with an adjustment disorder, but over that timeline, it may have actually, they might have now be meeting the criteria for a major depressive disorder. Ergo, you could then diagnose to a major depressive disorder if they meet all those categories. So that's just A. They've got to meet all of that. Then if they meet that, you go down to B, obviously. That clinically significant impairment, what is that? Well, I tell my students about, have you noticed a qualitative change? They were studying a lot, now they're not studying. They're usually at work, half hour early, now they're having trouble getting there. So just those kinds of things to be listening for. Then C, of course, is you have to rule out substances and medical issues. One of my great moments as a clinician was I went to a seminar like this. They talked about that very same thing, and they talked about thyroid conditions and how that can mimic depression. So, of course, the next day, one of my early clients was talking about it. I said, well, you should go to the doctor, So she did, and she came back, and she actually had a thyroid condition. So my brilliance notwithstanding, it's just really easy to look over the fact that you have to rule out those medical conditions. Different types of medications can have people a little bit down or gaining weight that might mimic some of the symptomology. So just FYI on that. So now you've got those things. Now it's not just major depression. Now you've got to really clarify what version is this person experiencing. So you've got course specifiers, so single episode or recurrent. So you're asking, have you ever experienced this before? If so, when was it? What can you tell me about that? What were the triggers, et cetera? So you either got a single or a recurrent episode. The severity is going to be based on the number of symptoms in that 1 to 9. So mild, I think, has 1 or 2, and then up the line in terms of that. So you're not just noting these symptoms for no reason other than, yes, they meet it, but it also plays again into the severity indicator that you use. Again, a room full of healthcare professionals, you probably know that people can have psychotic features within depression. My experience was a lot of paranoia I would kind of see a lot with major depression, but people having hallucinations and things like that within the context. So when I was in my training, it was easy to go, oh my gosh, they must have schizophrenia or some other kind of psychotic disorder. If you hear that kind of stuff, don't forget about this could just be a part of depression. And then the last part is the specifiers. If all those other things weren't long enough in terms of making a diagnosis, there's all kinds of different specifiers. So previously, if somebody had a lot of anxiety with depression, you would have to give them another anxiety diagnosis if they met that. So we know there's a lot of anxiety for a lot of people within the context of a depressive episode. But now you've got these specifiers with anxious distress all the way down the line. And there's a lot of different elements to the specifiers. So in the red at the top, that's how you would code that. major depressive disorder, single episode, mild with anxious distress. So I put that all up there just for the benefit of knowing that when people talk about depression from our standpoint, there's a lot going on that has to be clarified before you really have the right version of that for that person. Again, with the persistent depressive disorder, there's not as much symptomology, and then the timeline, of course, gets attenuated a lot. And then they also have the specifiers, and the specifiers here, some of the things to note, is in partial remission, in full remission. You know, again, it can remit for these different times. People say, oh, I'm not depressed, so that must not be part of what's going on anymore, but it actually can still be going on. So your assessment questions, you know, can be very targeted, very intentional once you kind of know that that's all part of it. The other specifier, if with pure dysthymic syndrome, with persistent major depression, so again, there's that specifier of a major depressive disorder might manifest within the context of PDD, so it's all kind of fun, right? A lot of evidence-based treatments. The empirical support is pretty clear at this point. Psychotherapy helps a lot with depressive disorders. Antidepressants work well. In combination, they work really well together. Okay. If on the bottom there, if you take out the meds, if you just keep them on meds without the counseling, there's also a sense that, well, maybe it doesn't remit as quickly as it might if you were keeping them with the counseling. Now, I'm not trying to suggest that because we want everybody in our offices for counseling, but a lot of times when, I'm sure you do this too, when you're talking to patients or families about medication, it's a lot about, at least in my world, it's about that isn't going to take away whatever that situational or kind of ongoing element in your life is, but it helps you get your feet on the ground so that you can address those issues in a better manner, et cetera, et cetera. So not a particularly sophisticated way of looking at it, but a very real way of helping people understand the medicine in relation to actually working on the problem. So there's numerous evidence-based treatment strategies. Cognitive behavioral is one that often gets, you know, a lot of play, and for good reason. It's a very good framework for helping people deal with therapies. If you're old enough to remember Irma Bombeck with the old "life is not a bowl of cherries" kind of approach, I know I date myself when I say that. So don't feel afraid to raise your hand and go, yes, I know that. But a lot of times with CBT, if it's not something that you're studying a lot, it can really seem like that. It can be described like that of, okay, you identify those negative thoughts, and that is good, and you can start putting in interventions to do that. But really, making a qualitative change from a CBT framework really requires getting down to that kind of core schema of what's going on that kind of triggers that negativity. So, for example, a pretty common one is, I'm not good enough, right? You've probably heard that at some point from somebody in your life. That kind of come up and gets in your head and starts spinning around a narrative of, I can't do that, et cetera, et cetera. So you can slow that down, but ultimately you want to get to the core of that. And that can sometimes take a while and involves restructuring and things like that. The mindfulness-based cognitive therapy is gaining increasing positivity for very good reason also. I'll address that in a couple slides moving forward. The behavioral activation approach, that's one where, you know, that sense that when people are really struggling, that they might just stop doing things that they normally like to do that I talked about earlier. So kind of getting them back doing things that they normally did so they can get their routine back. If it's exercise, for example, we all know that helps with depression and anxiety too, but that's just a kind of an approach that really focuses on getting them back on the horse, either literally if there's a horseback rider, or getting them back doing things that they know that helps them in terms of their own wellness. The interpersonal psychotherapy, that version of it is just very collaborative relationship building, using that relationship as kind of a Rogerian approach, if you will, of within the context of that relationship, they'll feel free and safe to start exploring things that are maybe causing part of that depression or anxiety. And then the adjunct therapies, ECT, not ETC, excuse me, that, you know, has, as you probably know, it's not like people like, you know, all kinds of electronics. It's very subdued, but it's used for more severe versions of it. The bright light therapy, I grew up in central Wisconsin. I didn't even know that in November, until I moved out of Wisconsin, that in November you didn't have to be cold and gray skies. I moved from there to Vegas, and one of my wonderful moments was in November riding my bike to class and realizing that I couldn't figure out why I was feeling so good, and it was because it was November and sunny. So there are all kinds of different light therapy versions out there. Not a bad idea for, I may be talking to the choir on that one given where we live, but the vagus nerve stimulation, I really don't know much about that one, to be honest, but it is in the evidence base and in the psychopharmacology, of course.
Biofeedback?
Yes, biofeedback, neurofeedback and biofeedback, yeah. A lot of good evidence of that too. So, and I would go into all of those, but you can have a seminar obviously on all of those. So I'm a dog lover, so anytime I can throw a dog cartoon up there, I will. But a lot of what we're talking about with mindfulness and those kinds of things, people struggling with that perseverating part about cognitions and how that leads to depression and burnout and et cetera, this is kind of a good kind of entry into how that stuff just starts going in people's minds. So the mindfulness approach is very much going from that active brain doing things, you probably have heard this, to just kind of being in the present. Well, if you're somebody that's got that stuff spinning in your head all the time, it's really hard to just kind of be in the moment and understand what's going on with you, not just cognitively, but physically. So that's really what that is. Here's just the treatment protocol for it. It's about, I think it's 8 weeks or so. And as you can imagine, it starts out with just trying to calm yourself down and then kind of moving into awareness of the cognitions, awareness of the body, and changing your perspective that you can calm down. And when you're in the moment, things clear up a little bit. Does anybody do that kind of mindfulness work? A couple people do. Yeah, it's the research on it is very positive, as you can imagine. Okay, so into the bipolar, I was really excited to find this slide because it's really easy if you're not aware of what the bipolar disorders are and related. If you follow the green, it goes all the way up to mania. So a person with bipolar 1 disorder has to meet the full criteria for a manic episode. Then it goes all the way to the other pole, has to meet full criteria for a major depressive episode. So there's a lot of diagnosing that goes on for somebody to be bipolar 1. And I always use examples of Hollywood. I watched maybe too much TMZ. But that notion of, like Charlie Sheen, if anyone remembers when Charlie Sheen a few years ago was having clearly a manic, I think he admitted to that at one point. He's having a manic, going through a manic phase. And he was talking about tiger blood, and he was doing like weird, Charlie Sheen kind of presentations and things. And I'm a Charlie Sheen fan, I should say. But he was doing all this stuff. It was all mania, or driven by the mania. And the lay people often just, if somebody does something a little maybe eccentric or wild or something, says, oh, you must be, the person's bipolar. And they're generally, in my experience, talking about bipolar 1, which is the mania. So if you note the red, if you can see it, the red of the bipolar 2 gets up to hypomania, doesn't reach full mania, and then all the way down, but does reach a full major depressive disorder diagnosis. So again, they're elevated, and you're seeing some of those kind of almost manic elevation, but then never reaches it. But then people forget, goes all the way down, so to speak, to the major depressive disorder. And then again up to the euthymic, kind of the stable. Yes, ma'am.
How do you define a manic episode?
Okay, thank you for asking. I've got 2 slides to get you through that one. Well, I would, before I get to that, if you would just hold on one quick sec. The cyclothymia, that's one that not a lot of people have heard about. Has anybody heard of cyclothymia? A couple people have. But this is kind of that in the middle. It reaches hypomania, but never reaches full major depressive disorder, and it never reaches mania. So you've got somebody just kind of in the middle of doing that. So in my experience, this can be harder to diagnose because they just never quite meet something. They think, well, they've got to meet that before I diagnose them. They're just kind of in the middle. So they're sneaky. If you're looking for a sneaky kind of depressive bipolar, that's where it is. Okay, so again, and so my defense on this is I just want you to have that information. That's why it's so content heavy. But this is the much easier slide to follow. So if you're a glutton for punishment, I can go back to the other one, but this one kind of touches base on it. So for a manic episode, the time frame is just 1 week. Now it can be just 1 day if the person's in the hospital, right, or whatever that is. But 1 week you have to have that mania for. For a hypomania, and then at least 3 symptoms in the kind of the lighter color there. And then what's the difference between mania and hypomania in the sense of the behavior? Well, the mania, it's elevated again, right? So that grandiosity, somebody might have like a good sense of self-esteem, right? With mania or with hypomania, you might see that up a little bit. With mania or with hypomania, might add a little bit. With mania, you might get into like the Charlie Sheen, I have tiger blood, those kind of, I'm 10 feet tall and bulletproof. That kind of stuff might be an indicator that, we've reached mania versus hypomania in that sense, in terms of the grandiosity. So it's important. The grandiosity is one that always kind of calls attention because it's kind of overt. But the decreased need for sleep, hyperverbal, flight of ideas, they've got all kinds of great ideas. They have the greatest idea in like a multidisciplinary greatest idea for the moment. That can be kind of an indicator of something to listen for. The goal-directed activity, there's a lot of really amazingly creative. I think Beethoven and the creativity piece can really get jacked up. They can do amazing stuff, but there's a precipitous drop-off at some point because the mania will eventually stop. So again, the marked impairment of social occupational, so not going to work, or going to work and saying, I've got all these great ideas and nothing's getting done at work, those kinds of things are things to pay attention. The psychotic features, the delusion, hallucinations, paranoia, those kinds of things you see a lot with mania that you don't tend to see with the hypomania. So it may take a little, you may have to see somebody that's in a full mania versus somebody that's in a hypomania to really be able just to kind of experience what the difference is, because it can be a little challenging if you've never been in the middle. I've never, in my experience, I've never hospitalized or been part of hospitalizing somebody that had hypomania or was bipolar II that was based on the hypomania. In my experience, it's always been they've gone down to the major depressive disorder, and that's where the hospitalization occurred. So you tend not to see the hospitalization with the hypomania, but you tend to see it with the mania. Does that help at all? A little bit. So there's a lot of evidence-based practices. The relapse prevention, if somebody's been diagnosed with bipolar disorder 1 or 2, a lot of the work that I did and that colleagues still do with that is really around psychoeducation. If you know somebody that has bipolar disorder, you've probably had a conversation of this is something that you didn't do anything to get bipolar disorder. It's a brain disease, so to speak. Well, not so to speak, it is. But it's not going to go away. So it's that consistent lifetime thing of trying to explain to somebody that the best thing to do for that person may be taking medicine for the rest of your life, or at least for a long period of time. And so a lot of psychoeducation about what bipolar is, medication compliance, those kinds of things. And particularly in this family psychoeducation approach, I really like this approach. And I used it a little bit before I went back into higher education. But that was, if you could get the family in the room, was very beneficial. Because not just, say the person that has bipolar is struggling with understanding what that is, family certainly would be struggling with it, and to help family members understand that this is what's going on. Person's not crazy, et cetera, et cetera. This is what bipolar is. This is a symptomology of it. And then what was even better than that was helping them understand and really work together and communicate on those prodromal systems of really understanding that family member's real nuanced version of what their triggers are, And so family members often see it, of course, before the person does or acknowledges it. And so helping them with their communication and problem-solving skills of saying, my brother has bipolar disorder, and as the family, we're aware of what the prodromal symptomology is before he is. And being able to communicate that to him without shutting him down so he doesn't get mad and doesn't take his medicine or something like that. So all those kinds of discussions that you can imagine might happen, that family psychoeducation approach is really, really helpful if you can get the family in the room, which is a big if a lot of times. The CBT again, the interpersonal and social rhythm therapy with bipolar disorders is interesting in the sense that it really views the triggers as kind of something in that person's daily routine has gotten disrupted, their sleep patterns are disrupted, so it really focuses on getting that person back to a positive baseline of that. And you can do it during an acute episode, which in my experience does not work as well as shortly after, where the person's more apt to be open to listen to it and be able to kind of talk through it and discern it when they're not in an active stage. And then DBT, dialectical, that's often used with people that have bipolar disorder, or not bipolar, has borderline personality disorder. Because of that mood dysregulation, that's pretty typical of somebody that has a BPD diagnosis, and it helps with you can do a lot of those things of helping with like managing up and down, lability in terms of emotions, coping with these up and down emotional states in a different way. So DBT is a very, very effective therapy for that. There's just Google it, or Amazon, whatever. The Linda Hand is the key person if you're looking for that. She's done great work there. The anxiety disorders, and I know I'm going to have to kind of rush through this a little bit, or a lot. So the key to remember is there's good information here, but there's a lot of different anxiety disorders, and it's easy to get wrapped up in somebody had a panic attack, ergo they have all different kinds of things. So just the panic disorder, that's a panic attack is not panic disorder, and those things get conflated a lot. You can have a panic attack at different times in your life. I hope you don't, but if you do, it doesn't mean you have panic disorder. So the panic disorder is that, well, I'll get to that in a second, but just don't equate that. And if people say I have panic attack, I have panic disorder, just say no. Let's figure out what that is diagnostically. They have to have one, and then there's that period of about a month after that where it's just constant worry, am I going to have another panic attack? And not just that, but it's changing that one's behavior so that you're not in the same place where you had that panic attack. So you'll see people are taking different, you'll see different behaviors of avoidance, so they're not in the same place. Specific phobia, there's the kind of the big four that people tend to have. When you're working with that, it's a lot of kind of working with them to identify specifically what that is. Again, I'm a dog person. In particular, I love dachshunds. And I once had a client, or a student that just was so fearful of dachshunds that I just could not understand. So I kept trying to find, it must be another dog that you have this, but it was specifically dachshunds. And as you found out her story, she, of course, had gotten bitten by a dachshund growing up. So, it's not just the animal, but what was the connection between what that is? And it might not seem, reasonable or even rational to you, but that doesn't matter. We know that. But taking the time to really explore what that is important. Agoraphobia used to be connected with panic disorder, with or without agoraphobia. Now it's its own diagnosis. And that, of course, is that fear of being in a place, usually a bigger open place where you can't get out of. There's no escape. If you've ever watched that hoarding show, if you couldn't sleep for some reason or you like that, a lot of times those folks have agoraphobia. They are scared to death to leave the house, to leave the safety of their house. So social anxiety disorder, which is great for an introvert like me that gets up and talks in front of people. It's not just that kind of fear of talking, which is pretty normal. It's one of the biggest things that creates anxiety for people. But it's that really high self-consciousness, being judged by others, making a fool of yourself and other people. Most people identify with that to some degree, but doesn't rise to a clinical level. Separation anxiety, you'll often see that with younger kids, but you can see it maybe developmentally delayed people might be a little age-wise there. Um, the generalized anxiety, that's that kind of overall, just a lot of different things are going on. Everything makes somebody anxious. I have an aunt that it does not matter. Like whatever the issue is, it makes her anxious, and then she makes everybody else anxious. And I once said to my uncle in a closed space where she was not there, I said, I wonder about Aunt Lou. And then everybody got mad at me because I was diagnosing family members. So don't diagnose your family members. But if you see somebody that really struggles with all different kinds of things and just everything rises to a big level, there is this generalized anxiety disorder, and it really responds well to counseling and psychopharm interventions. Again, the panic disorder, anybody work in the ER or have worked in the ER? The number of people that present at ERs with a panic attack is very, very high. And so a lot of times, a lot of the referrals I would get at the nervous clinic down the road where I worked from the hospital was folks that had their first panic attack and had no understanding of what that was, except, well, I'm going to die, take me to the hospital. And so we would spend a lot of time kind of going over the situation, because you can see there's a lot of different types of panic attacks. And one of the really scary ones is you can have a panic attack when you're sleeping, which really kind of freaks people out. They wake up having a panic attack. You can imagine that's not a fun wake-up call. But really taking your time with people to explore, so you had a panic attack. It may have just been random, like something you might have just not gotten enough sleep or something, whatever it is. But the spontaneous ones, people want an answer. And when I had clients that had just one, they were really upset with me when I couldn't magically come up with what it was. But the situationally cued ones are really interesting and really take some time, because, for example, you're in Walmart. You had a panic attack in Walmart. So, okay, but you've been at Walmart a lot of times. Or you're in Walmart and you had a child with you. Or you're in Walmart and you had a child and somebody got mad at your child. Or you were in Walmart, had a child with you, somebody yelled at your child, and then you saw somebody else with a child that was being able to discern exactly what that trigger was might not seem, it might seem obvious. Well, you were there and then you had this. We know that's not that simple, but just helping clients feel safe enough to just explore that, because if you're exploring that in a real way, they might kind of hold off from what that was because they don't want to have another one, even if they're in Walmart. So panic attacks are really scary for people. And again, the treatments, CBT works well, panic control, the acceptance and commitment, the exercise, psychopharm, that stuff all works really well. Creating a safe place. I known people that would, with the panic control, would get people like running in place. I use that example to kind of recreate that anxiety, feeling tired again that they might have experienced. I know of this, I do not recommend this, and I've never done this, of actually putting somebody in a situation where they re-experience that panic attack. And then they experience it in the safety of your office, and then you work through it. I've seen it done, and it was effective, but that person had a lot. Now I could probably do it and feel enough efficacy to do it. But so there's a lot of different ways people do that. Trying to tell a client, how about if we trigger your panic attack, and we'll just work through it in here. You, of course, have to be thinking about your relationship with that person before you try that. Also, with the benzos and the SSRIs and stuff like that, early in my career, people were prescribing benzos for that. About midway through my career, that just pretty much stopped, And it's working with the SSRIs in a severe case. Don't get me wrong, but usually it was the SSRIs and the psychotherapy combined that we're really kind of focused on and working with that. And just for time, I'm going to kind of go through these because I know, again, this is all meant for you if you got bored that you can go back and look at this later. There's some good information here. Generalized, don't forget about play therapy, music therapy, creative arts, expressive arts. There's all kinds of things that you can use to help people struggling with these. The burnout and depression, so burnout is that physical emotional depletion. And I bring this definition because of the work-related, the negative work environment, or the stressful work environments that we all work in. If you count a college classroom as stressful, maybe you do. I hope you do. several years ago, I worked with some colleagues who did a counselor burnout inventory, and I just want to show you a couple things here because there's no nurse burnout or something like that inventory. There's not really, but this was what we came up with the types, and nobody cares about the well-adjusted counselor. The disconnected counselor, you start to see increasing the devaluing the client and a sense of incompetence, and then the work environment. So this is all elevated a little bit, but what I really want to call attention to is the persevering counselor. Now, you know, in the culture I grew up in, you just keep going. If something's not going right, keep going. Doesn't matter, it'll eventually work it out, or the state motto of Wisconsin is everything's fine, right? Everything's fine. It doesn't matter what it is, it's fine. And so I am responsible for the title of this. We published this in a really good journal, and you know, we're real proud of it, and we were going around talking about it, and I think probably trying to humble brag about it at that point because we were early in our careers. But we kept talking about this persevering counselor is really good. That's great, because if you're a persevering person, your burnout's not, we had it all wrong, right? So what we found when we really looked at the data, and is if you look, this is an interesting kind of line here. So what you've got is you've got exhaustion, negative work environment, and deterioration in personal life, all very high, very elevated. And so here's my devaluing the client, Wisconsin, everything's fine thing, right? So you're not devaluing the client. You're still focused on your client. The client may be the thing that's keeping you going when everything else is going to hell in a handbasket, so to speak. So the persevering counselor, and I would throw out there, I'm not generalizing to mental health, you know, but just something to be aware of. If all of your focus, everything else you're really struggling with in your life, and you've still got that focus, I still am taking care of my clients. My statement to you is take a real good look at that from a self-reflection standpoint. I'm not suggesting you're not taking very good care of your clients. You probably are. But that overcompensating of I'm taking care of my clients when everything else around you is not going very well is a recipe for burnout. Now, we know that intellectually, but we all also take care of our clients probably to the maybe not focusing on us as much. So that's why I put that in there. And when you start looking at the burnout literature, and I'm kind of a rube a little bit with that burnout, with that literature. So I found some good articles. These are all the different things that are connected with burnout in healthcare professionals. And you know, when I was going through that, I was kind of going, wow, there's a lot of pretty serious issues going on there. Again, I figured that intellectually, but to see the empirical evidence of that is, you know, alarming in the sense that we have a lot of work to do as, you know, healthcare professionals in taking care of ourselves is basically what I'm suggesting to everybody. But you see the outcomes of some of that, some of the implications of that. It's severe across the board, not just for our well-being, our job satisfaction, but for client care. So, and just some quick, with the medical students, you saw like 27% burnout and depression. And nurses, there's not a lot. So if you're a researcher, there's a lot of openings there to do some burnout research. And if you're interested in that, let me know, because I would be very interested in working with you on that. And then the physicians, there's a recent, this topic, you know, 54% of burnout, and that's related, of course, to depression and those things too, but 6.5% suicidal ideation. So over half of the physicians are reporting burnout. That was shocking to me, because I don't get in that literature much. That's a lot to me. And I know, just like you don't want to go to a counselor that's burned out and fried and depressed, you don't want to go to a physician that's feeling those same things. So again, this is my last kind of part is real quick with the suicide. If you hear somebody talking about that and you are like, what do I do? See if you can change even briefly one of these. The inescapable thing, there's nothing I can do about it. The intolerable, I can't handle it, it's going to happen, or the internal is forever, right? If you can just even briefly make them flip any of those, you're doing the right thing, that you can give them that little bit of time to get to a counselor, get to somebody else. I won't go through all of that. You can imagine nurse suicide. There's a little bit of research on that, but it's a lot of times what I read anyway, just in the few articles I read preparing, is connected to a negative work environment. There's a lot of negative work environment stuff going on about there, and I am not a nurse. All I know is when I'm in the hospital, I know nurses are working, how many hours and dealing with everything. So that's my overgeneralized, uninformed view of what a nurse does minute by minute, right? So don't think I know anything more than that. Suicide cues, there's a lot of different ones. And then this is just information. I just wanted you to have this for later on. If nothing else, go through and review all those suicide myths so that if you're listening to somebody talking about a myth like it's an irrational act, right? Well, a negative work environment, it's a rational act. Suicide can sometimes be one of the most rational things to that person, right? Why wouldn't I do that? So there's a bunch of them. Here's my last minute here. In counseling, we use the wellness philosophy, right? And the wellness philosophy is health-enhancing, preventative, strength-based. That's how we go about that. I'll talk out both sides of my mouth because I train our clients on the medical model. I train them on the DSM. So you got to know that if you can't do that as a counselor, your client's not going to get the care that they need probably. So, but in terms of care, this model is very strength-based, so it takes the stigma out of working with clients, right? We're not worried about something's wrong with you. We're concerned with what are your strengths, what are your natural strengths, and so that's how we approach it. And it's choice-oriented. You're talking about connecting all people's strengths, kind of an individualized manner. This is the model in that form. So there's total wellness in the middle. Then you've got these 5 second-order factors, which are broader areas where people have strengths. What I really love about this model is this element. This is an obnoxious amount on a slide, but it breaks it down. These pieces in the bottom there are all strengths. And to look at this, just thinking doesn't mean somebody's smart. It's operationalized in a way. It talks about critical thinking. How do people utilize their intellect in ways for emotional regulation? So it's a once you really understand what these are, you really get a better sense. It's a much more broader understanding of friendship or love or emotions, and it really helps you understand that person's strengths in a particular category, and you can individualize that to a treatment plan with them. And there's just a bunch of ways to utilize that. And here's a couple strategies, the Wheel of Wellness, to really focus on your own wellness and see how that kind of breaks down a little bit. Here's just a couple different versions of it. And then my last kind of comment is, again, I do research on wellness, and, I present it all the time. And my students will say, and they'll see me in my office with, Mountain Dew bottles everywhere and, hypothetically a Twinkie wrapper or something like that. I don't eat that well. I don't do the things as well as I should that I'm talking about. And I throw that out there because my experience has been those of us that are taking care of other people tend to forget to take care of ourselves. So that's my last little comment on that. And again, if you have any questions, if you want this PowerPoint, I'd be happy to share it with you. If you're interested in any other pieces of any part of that, please feel free to email me or call. I'd be more than happy to talk to you or come meet with anybody else in a kind of a smaller setting. Thank you very much. Anybody have any questions? Yes?
When we talk about depression, we still have many medicines that can treat that, but it just takes so long for the patients and families to see a positive benefit from that.
Mm-hmm.
I mean, weeks to sometimes 2 months almost.
Right.
Will we ever see a change in that, or it's just very frustrating? And if
yeah.
you see patients in the hospital that are depressed, we certainly encourage that maybe once they get discharged, their PCP can order something, but it just doesn't work like an antibiotic does, so therefore
Right.
they just stop taking it. Any thoughts on that?
That's very true. I would defer to my psychiatry friends on that one in terms of where those medicines are going. From a counseling standpoint, we tend to address that through psychoeducation, of really doing the best that we can to inform clients of this is not a one-to-one, you're going to take this and your headache's going to go away. So really to your point, I wish I had a better answer, but it's really from my standpoint psychoeducation. The more that person leaves your office or what's ever going on, with at least the general idea that I'm not going to take this and wake up feeling better. If they're leaving, if you're seeing them in the hospital and you're not going to see them after that, I would focus on that. I would focus on the psychoed piece that you're already doing. I wish I had a better answer, but that's about it. Yes, ma'am.
I had a question about trichotillomania.
Okay.
Is that treated, or is there any research about being treated by medications versus?
CBT is used a lot with that. There are something that can stop, because it's anxiety. There's a lot of anxiety with it. Well, it's actually, they took it out of the anxiety categories into the OCD and related categories, so it's viewed diagnostically more in that sense.
As OCD?
Yeah, as OCD oriented, with the focus on that. So, yeah, so I've seen it treated with anti-anxiety medications, but it's always been in combination with counseling, trying to help that person through it. When I've seen trichotillomania in my office, there's a lot of adults developed it a little bit later because maybe they had some childhood sexual abuse or something else that they kind of had memories of, and they just didn't know how to deal with it. So the trichotillomania was a kind of part and parcel to helping them deal with that. With trichotillomania, don't forget, if they're not just pulling their eyebrows out or their hair, they might be pulling hair out from legs, private parts, things like that they can hide from people, which was pretty common too. I know I'm over my time, so I thank you again.
Hey guys. Awesome. Nice to see you. Nice to see you. Everybody awake? I know. It's in the afternoon. My brain's been someplace else. I was like, all right, Mel, get it together. You got a presentation this afternoon, right? So we are, like I said, for those of you that I don't know or that don't know me, I'm Melissa Strong. I'm the service leader for the chaplains for the spiritual care services here at Methodist. And I've chatted with a lot of folks about behavioral health stuff, and today's a little bit different. We're going to take a piece out of the CPI training, and then we're going to kind of blow it up a little bit. So we're going to talk today about our own stuff, which is hard to talk about sometimes, hard to think about, like we'd rather talk and think about somebody else's stuff, right? But today we're going to talk about self-awareness and triggers in the workplace. So what are my buttons? And how do my buttons and my triggers affect the way that we deliver patient care? So, so that's kind of where we're going to go today. So we'll see. I've never done this presentation before, so we'll see how this one goes, right? So today we're going to learn about the causes of workplace stress, discover the definition of precipitating factors, and begin to name and understand our own precipitating factors. Increase self-awareness of our own behaviors that arise when we are being influenced by said precipitating factors, and discern my own current forms of coping skills. If you talked with me or been with me about coping skills, we can talk about all kinds of coping skills, but we'll get there. And identify ways in which we can grow. So we need to start with what our goal is, right? Our goal is for a healthy environment, right? A healthy work environment. Debbie, is it hard for me to walk around? Is that a pain for you? Okay. Okay, all right. Be like camera ladies all over the place, like, Melissa, just stand still, lady, right? So we're going to talk about what a healthy environment is, right? Because that's really what our goal is. Our goal for a healthy work environment is healthy for us, which makes it healthy for those patients, right? And so the World Health Organization says, as health is not merely the absence of disease or infirmity, but a positive state of complete physical, mental, and social well-being. A healthy working environment is one in which there is not only an absence of harmful conditions, but an abundance of health-promoting ones. So I really liked that from the World Health Organization, because that talks too about the importance of us, an individual. Like, I may not be bad, but that doesn't necessarily mean that I'm good today. You know what I mean? Like, I may not be in a grumpy mood, but that doesn't necessarily put me up for really great patient care either, right? So we got to make sure that we are aware and making choices for ourselves that set us up for success, not just our patients. Because Lord knows we can become a precipitating factor, and we will talk about that, okay? So let's talk about workplace stress. So before I go through this whole rigmarole list, what are some of the biggest stressors that you all have in workplace? What makes your workplace or workplace in general stressful? Overwhelming workload, okay? What else? Yeah, interruptions. Are you type A? Like when you start something, you like to do it, like don't interrupt me? Yeah, I totally get that. What else? There's only two? There's only two? That's it. That's the only things that make things stressful, right? What else? Yeah. Mm-hmm. Well, yeah, wanting to fix something and maybe not having the tools or the support or whatever it is to fix said thing that has been identified, but you have no power to actually fix it, right? Yeah, totally. What else? Human beings. Human beings, right? I've said before, like, I turn around the tag when I say these things, but like, you know, this work would be a whole lot easier if I didn't have to deal with people, right? Right? You know, like that's it's human beings make things hard because we all have our different wants and our different desires. We all have goals and then things that we want that we don't say that we want, but we expect you to complete, whatever that word was that I was thinking about, but we expect you to do the thing that I want you to do, even though I don't tell you that I expect you to do that thing, right? And that is in all areas of our life. That is not just work, right? So here's a bunch of different things, right, that people have identified as workplace stress. So task design. Now this is a more general study that is not just work like healthcare environment, right? So task design, workload, exactly what you said, right? Overload or underload. Sometimes people are stressed at work when they don't have enough to do. Not that we know anything about that, but shift work or the hours that you work. Sometimes that creates more. Lack of appreciation. That's a big one too. Role in the organization, role conflict. Even how many people are telling me to do different things, and which one, if they're different. I used to work at this job where I had 5 different managers that I reported to, and I did payroll for all 5 different managers, and that was amazing. And and depending on the person, I had to figure out which one was more priority, and then I would inevitably make one mad because I prioritized somebody else above that person. We deal with that too in our environment. We have to triage, and sometimes the people that we triage less don't like that they've been triaged less or second, right? So these are all different things that we deal with in stress, as far as workplace stress. Career development. Is this as high as I'm going to go? Is there someplace else that I can go? For driven people, especially career-driven people, when you feel like you're at the top, that in and of itself can be a place of stress. Or if you don't know where you're going to go, that can be a place of stress. Relationships at work. Sometimes we have good ones. Sometimes we have tough ones. Lack of relationships in and of itself. Isolation. Talk about human beings. Human beings don't want to be isolated, right? So to feel like you don't have support at work, or to feel like you can't go to your supervisor, or to feel like you can't go to your core, whatever that is, those all can cause additional workplace stress. Organizational structure. Not that we know anything or have any frustrations about organizational structure, right? Bureaucrat stuff, right? But lack of systems in the workplace available to respond to some of our concerns. I think at Methodist, we are doing a better job at stuff like that. We are trying to do that, and I think we're doing better. But also work-life balance. When you work 12-hour shifts, and sometimes your kids are in bed before you go to bed, or before you get home, and then you have to be at work before your kids actually get up. Like, that sucks, right? So, making sure that we have good work-life balance and that we do take care of ourselves. So we set ourselves up for this craziness, right, of all this stress that's on top of us. And these are any environment, let alone healthcare, right? So then healthcare, what makes healthcare? How many of you have friends that are not in healthcare, right? Do you guys talk about workplace stuff sometimes? What are some things that make your environment more stressful than their environment? We're just going to pretend we're going to do the compare thing, right? That people tell you never to do, but we're going to do it anyway. What makes healthcare more stressful? Life and death. We're dealing with like the meat and potatoes of what it means to be human, right? Yeah. And one slip up on your part, one day where you're not paying 100% attention, it's not like somebody gets paid the wrong paycheck, right? It's a different deal, right? What else? What makes it different?
Caring, like spending all day caring about somebody else and then going home and you're just like,
Yeah.
nothing else.
Talk about burnout that you guys just had, right? You get to work the next day and you're like, I don't want to care about you today, right? How many of us have had those days, right? You know, let's be honest here, right? I'm an honest kind of person. We just call it like I see it, right? Yeah, totally. We pour out. And if we don't start pouring back in, we have nothing left to give. What else? What makes healthcare more difficult?
Maybe it's not as predictable. I mean, every person reacts differently. There's just a lot of variations.
Mm-hmm. We never know what we're going to walk into. We never know what we're going to walk into today. And for some people, they love that. And for some people, they don't love that and probably should find a different job, right? But that's the reality of this situation, right? Is that we never actually know what's going to happen. Absolutely. What? Anything else? Anything else that when you talk with your spouse or you talk with your friends and you're like, yeah, you got no clue. This is totally different. This is yeah.
Constant change.
Just
New medicine, new technology.
constant change. New medicines, new rules, new connections, new physicians, new staff, absolutely. What'd you say?
Don't forget body.
Body fluids, right? There's a reason why I do not wear gray scrubs. I'm just saying, and you named it. Right? Now, put me in a trauma room any day, I'll thrive as a chaplain. But the rest of this, no, thank you, right? Yeah. But that in and of itself, right? My mother was a nurse, and my dad was a chaplain at a hospital, level 2 trauma center. Our dinner conversations were not, keeping up with the Joneses, right? It was like, why did you talk about poop at dinner last night, right? Those are things that totally. People don't get it, right? Yeah. So my husband is a correctional officer at Douglas County Jail. Trust me, we don't have normal conversations at our house at dinner time either. Those are crazy things. Anything else that you can think of that just makes
Wear and tear that physically on your body.
mm-hmm.
Physically being on your feet for 12 hours or 13
Yeah.
hours. Being away from your house for 15 hours.
Right. The physical toll on your body, for sure. Right. Let alone, turning or bathing, 200-pound humans or more, right? I mean, that's hard. That's hard on our bodies. That's hard on our joints. That's hard on our head. We get headaches, fluorescent lights all the time, that kind of stuff makes a big difference, right? So then we get into this situation where we have all of this crazy workplace stress, all of this stuff that we deal with, and then we add in our own human component, which is amazing, right? Because we don't have any of that other stuff that other people have, right? So let me just tell you a story. This is a fictional. See, you just say something and it's a real word, right? A fictitious story, right? So let's start with last night, right? So last night I got off work late, okay? I got off work late. And on my way home, I forgot to stop by the dry cleaners to pick up my husband's suit that he needed for work, for a big presentation today. So I get home and I tell him, oh crap, I forgot. And the dry cleaner is already closed, so I can't go get it. He says it's okay. It's all right, fine. But he's already acting irritated, right? We know that he's irritated, even though he's not saying he's irritated. But then I realize it's 25 minutes before my kid's bedtime, and my kid doesn't even have dinner yet, right? What were you doing all day, for crying out loud, right? What were you doing? So then I make dinner, and I put the kid in the bathtub, and because he's had a long day, right? And I feel bad. I feel bad that I had a long day. And I feel guilty for forgetting to go by the dry cleaners. So then after we get the kid to bed, right? My husband and I go, we clean the kitchen. I do laundry. He tries to iron his shirt. It's terrible. He doesn't iron very well, right? So then I re-iron his shirt, and I have to do that because he doesn't know how to do that. So I do that. Then I get to bed late, right? He goes to work early with his perfectly ironed shirt and pants. And then my kid wakes up twice in the middle of the night because my kid's teething, right? So I have not slept very well at all. So then I get up, I go to make my coffee. Instead of dumping the water in the coffee pot, I dump the water all over the sink and all over the counter. Then I have to clean that up. I have this beautiful cup of coffee, and I sit down, and what do I hear? Mom! What the hell do you want? Oh, wait, good. That's turned over, right? 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 So I start my day with that, right? Now, my kid has just learned to use zippers. So last night, sometime in the middle of the night, he unzipped his entire onesie and took off his diaper. That was lovely to wake up to, right? So then I go and I clean up that kid's stinking diaper and that sheet, and then I get him to dress, and I get him to daycare, and I go get in my car, and that guy cut me off. And then because he was late and I dealt with all that crap in the morning, then I get to work. And then my boss is like, why were you late? And here I am. And then I get into my patient's room and I say, open it. Right? That's what we're talking about. How real is that, right? We all have, maybe not all at once. Maybe I won't make you open it. Okay? But we've all had those days, right? Or parts of those days. So let's talk about what precipitating factors are, right? Precipitating factors are things that influence our behavior. Internal things and external things. So let's talk about that story, right? When we talk about internal factors, internal things that influence our behavior, what are some of the internal things in that story that influenced my behavior?
You have to iron your husband's shirt because he isn't good enough when he does it.
Right. Hello, Melissa, I'm a perfectionist, right? And it's not good enough, and it's my fault anyway, because I didn't get to the dry cleaner, so I feel guilty. That's totally an internal precipitating factor. What else? What are some inside stuff? Control, yes! Anytime we feel like we have to control something, that's totally internal stuff that's affecting my behavior. Absolutely. What else? Outside of that story, what are things that you deal with that are precipitating factors that you deal with? Internal stuff.
Just in a bad mood in general.
In a bad mood. Sometimes we just wake up in a bad mood, right? That happens. And when we're really tired, that makes it worse. Mm-hmm. And when we're worried about something, that makes it worse. And if we're at work and somebody asks us to do something, like if we've seen these nurses who go from a code directly into a patient room who's like, I got the red Jell-O and I wanted green Jell-O. If you don't have those precipitating factors in check, the things that come out here are probably not the most helpful things. We'll just put it that way, right? Yeah. How about external factors? What are some external factors? Things that are outside of ourself. What are things that influence your behavior that are outside of yourself? Your children. Your husband, absolutely. The guy that cut you off, that guy, I hate that guy, right?
Humans again.
Humans, right? Those teenage girls, that happen to be our kids. Like, it's a good thing I gave birth to you because I hate you right now, right? Yes, all of those things, right? So there are a lot of factors that we have to constantly be aware of in our own selves. And these are generally like shadowy things that we don't like to acknowledge exist within us, right? Like things that we're like, yeah, I just thought that, but I'm not going to tell anybody that I thought that because that means I am a horrible human being, right? We all have that stuff. We all have that stuff. So that's what, when we talk about precipitating factors, that's what we're talking about. So I want you to find a partner, somebody around, and I want you to kind of share something about you. You don't have to share this out loud. We'll give you an opportunity to if you want to. But I want you to share it with somebody around you. What are one of those things about you? Like, what is your thing? Or a couple of things. Like, what is it that when somebody pushes on that button, you're like, stop it, right? Okay, so take just a minute, and I want you to share with each other what is your thing, or a couple of things within you. All right. Did everybody get at least a chance to share one of them? One of your precipitating factors? Okay. Does anybody want to share out loud? We're all human beings here. There's no judgment here. So, who wants to share out loud? What was your factor? What's your thing?
I'll share ours. Since we were talking about husbands already, mine was telling me it's like, when you talk to your husband the night before about something, and the next day you get a text from him, it's like, we just discussed that last night. I don't even know the answer to that.
Yeah, that's okay. Yeah, so the husband that you have a whole conversation the night before, and then you get a text the next day asking the very question for the thing that you already spent 20 minutes talking about the night before, right? So when that happens, now that you've shared, what do you look like when you get that text? You look like that string. Yeah. What do you sound like? How does your behavior change?
They don't have any sound on text.
If you were to say it out loud, what would you sound like?
Are you flippin' kidding me?
Are you flippin' kidding me?
I'd be nice sometimes.
You would be nice sometimes, yeah.
I already yelled at him at home, and he's not even there. And the text is like, he can't hear me yelling at him. He's like, listen to me next time. We won't have to discuss this. Busy month in December. We have time to discuss things twice.
If you listen the first time, we don't have to discuss it 2 times, right? Totally. Yeah, we don't have time to discuss things twice, right? How about we act? How any of you, I know a lot of you, by your facial expressions, can recognize what it is that we're talking about. When you have been in this situation, how does your behavior change? What do you act like? What do you sound like? What do you look like when you are responding out of a place of like, yeah?
Short, snippy, kind of huff and puff. A lot more deep breaths.
What are you doing? I'm getting my Zen on so I don't choke you. Right. Oh, excuse me, pillow treatment. That's what I meant, right? Yeah. Yeah. So our face changes, the way that we talk changes. What else? What'd you say?
Our stance, the way we hold ourselves changes.
Oh, I'm sorry. I will move so you can actually see the video. There we go. Not that one. I don't know what that video is. Right? So much for that working. Right, but we get in, when we have this thing that we start thinking about, or if we get to work and we're irritated about that thing, and then everything like pushes that button, or even if we don't think, it kind of like pushes the button next to it, but it still pushes that button, right? I like this, right? So push here to make me react like I always do. Whose responsibility is it? Whose responsibility is my behavior? It's mine, right? It's mine, so I got to keep my own self in check. And part of what we wanted to do with this behavioral health series is not just look at what we do or how we learn about somebody else's behavior. How do we affect somebody else's behavior? How do I affect my own behavior, right? Because we are put into, just like we talked about all of those workplace stress, all of that stuff, we are put into extraordinary situations every single day that push us to the brink sometimes of what it is that we can handle in that given day. Maybe a different day we can handle more or less, but that given day, sometimes we are pushed to the brink. So we have to be able to get aware and make that self-awareness when we get on that hamster wheel of irritation, right? And we're just going. And no matter what we do, we've got to figure a way to get off. So how do you recognize when you are escalating? What do you, like for you personally, and this is, again, this is a moment of self-awareness, right? This is an opportunity for us to look within ourselves. How do you know, and what is it that changes in your body or your mind when you start to escalate?
Snappy, I can tell. My responses are not what they should be.
Yeah, your responses get snappy, yeah. For me, one of the things that I think in my head, it's a good thing that I have a really good filter. Because the things that I think in my head should definitely not be said to people, right? Yeah. What else? How do you tell when you are on that wheel?
I usually get like a headache or something, like tension.
Mm-hmm.
Again, I can't describe it very well, but I just feel it.
Like we can feel it in our shoulders or our neck sometimes. I get a headache right here across my forehead or like behind my eyes. You know those tension headaches? Yeah.
I just feel it like right here across my shoulder.
Mm-hmm.
And most of the time it's somebody says something to me and it's like no filter, whatever comes to my mind comes out of my mouth and I'm like, okay, yeah, I have to really go step in the break room or something.
Yeah.
Just know kind of when words just start flowing, kind of.
Mm-hmm. Mm-hmm. What else? What are some other things that you recognize about your own self? Especially at work. You'll never make it in prison, you're too pretty. Yeah. Those are thoughts. Yeah. Sometimes crazy little thoughts come into our brain and you're like, whoa, it's a good thing nobody can hear that one, right? Yeah. So, part of it is my own muscle. When we start, our own bodies, we've talked about some of those physiological things. We've talked about some of the stuff in your brain. My compassion and my desire to go see patients when I'm having one of those days goes down, which means the patient care that those people get from me probably isn't the best. So this is why we've got to be aware, because if we are dealing with these patients that are already dealing with their own behavioral issues, we don't want to become a behavior that, or a precipitating factor, a factor that influences their behavior in an escalating kind of way, right? So we've got to start keeping our own self in check. Now, coping skills. Let's talk about coping skills. So what are some of the things at work that you do to take care of yourself?
Time out.
Time out. Mm-hmm. Where? Alone. Anywhere alone, right? Okay. Put yourself in time out. That's good. I do that too. Deep breathing. What else do you do at work? Do you feel like you can take time away to like decompress for a second? You say no? Why is that? Mm-hmm.
So, I mean, to just get up and leave is not really an option.
Mm-hmm. To get up and leave that's just not an option. Uh-huh. So what can you do, or what do you do in those situations to help yourself cope in a moment where you literally can't get up and leave?
Sometimes I call, sometimes I just try to redirect myself.
Uh-huh. Yeah. And
Sometimes you reach out to me.
Oh yeah, I'm like, I'm about to lose my job.
uh-huh. I won't repeat that for the video. Yeah. Yeah. I mean, sometimes we need to make sure that we know our resources too, to know who we can call, when we can call, to make sure that we have what we need, right? Yeah. What are some other things that you do at work? Go find your work best friend and talk about it. Yeah. Yeah, absolutely. Absolutely. Take a minute for somebody that actually gets it, right? How many of you have a spouse that actually gets it? Like when you come home, you can talk about what you do, and they actually get what you do. Anybody have one of those? You guys a little bit? How many of you are like, my spouse has not a clue? Yeah? Somewhere in the middle? Not a clue? No? All the more reason why we need to have somebody who actually gets it that you can talk with about. Because what we deal with, again, is extraordinary circumstances. There are extraordinary circumstances that we are put in every day. What are some other things? Do you ever, you said deep breaths at work, talk to our supervisor, get some time away if we can. Sometimes even just going to lunch, right? Getting out of that space, physically putting something into our body, because Lord knows, hangry is a thing. You know, ask my 20-month-old. Hangry is a thing, right? Yeah. How about home? What do you guys do at home?
So one thing at work is
Uh-huh.
essential oils. Like if you don't have time to leave what you're doing, but for that split second, you can nurture yourself. I mean, like if it's a lotion or just an oil, I mean, just for a split second, you can use that to just put yourself in a different spot.
Yeah.
Even though you're right there.
Yeah. Essential oils. So I actually keep 2 essential oils in my desk. I keep a lavender, and I keep what's called a breathe. It's like a peppermint and some other stuff for my sinuses, right? But in that moment, if you close your eyes, it just completely transfers you to someplace else. Yeah, certainly. Certainly. How about home? What do we do for coping skills at home? Alcohol. Alcohol. Yeah. Peppermint schnapps and a little hot cocoa. I didn't have that last night. Yeah. What else? Exercise. Uh-huh. Yeah, watch TV. Yeah, yeah. Escape. Sure, sure. What else? What are some other things that you can do? Animals. Yeah. Pets. Very good. Yeah. Coping. Huh?
You can tell them all the stories you want.
Uh-huh. Uh-huh. You can. They will not. Well, my dog kind of talks back sometimes when she wants to go outside or something like that. But yeah, generally they don't talk back. They're great listeners, you know. Usually they don't smell too bad, you know. Yeah, yeah. I love this thing, right? Elementary coping skills, right? Is like, which bucket do we put in, right? Pouting. We can all have that option of pouting. Sometimes we need pouting, right? Sometimes. Nobody said good or bad, right? It's all relative, right? We have to have a good balance. Although I would not recommend the push the other person. That one is not a good idea, right? You know, pushing your patient when they irritate you is generally not a good idea to keep your job. Just saying. Stomping your feet, that could be a little bit different too, you know, in the work environment. But, you know, in all seriousness, my dad used to tell me, you know, it's everybody sometimes needs a little pity party, right? Don't wallow in self-pity, but it's okay to stick your toe in and swoosh it around a little bit, right? We all need those moments to be like, today sucks, so now that I've acknowledged it, I'm just going to sit here for a minute and then put on my big girl panties and keep on going, right? So to be able to acknowledge what actually is, and especially what is irritating you, you know, talking about those precipitating factors is really, really important, and acknowledging that, because it's just like, you know, a lot of times what I'll do is I'll talk about kind of physical stuff, right? So like a wound, right? If we just say, well, that wound exists, or if we say, nope, that doesn't exist, right? We're not going to be healthy if we don't acknowledge that it's there. And it's the same thing for our emotions too. So if we're irritated at something, if we're hurt by something, if we're feeling guilty about something, if we are grieving something, grief is a part of our work here. Like it or not, that is a part of our work. You know, grieving that somebody, it may not even be about death. It could be that we can't get them as healthy as we want them to get. Or watching somebody or listening to somebody with a loss of ability. That's grief just as much as somebody dying. Those are the things that we are immersed in. And those are the things that are really hard to deal with on a day-to-day basis if we don't have good coping skills. So we've got to make sure that we have that. So one of the things, too, have you ever seen something like this? This is hard to kind of read all this stuff, but these are the different kind of components of a person, right? Physical, psychological, emotional, spiritual, personal, professional, all kinds of different self-care, you know? And sometimes we don't think of things as self-care all the time. Yeah, you're welcome to take a bit. We'll send this to you too if you want that. So, you know, there's a lot of different things that we can do. Even, it's amazing if you can take 10 minutes off the floor with your lunch, grab your lunch, walk outside the South Tower, walk very slowly to the North Tower, and come back in. It's amazing what 2 minutes of fresh air will do for your spirit. It's amazing what that will do. Getting out into nature is something that is important. Not that, you know, like the cement jungle is nature, but, you know, getting outside with fresh air. Coffee, going downstairs and getting, I mean, our hospital coffee is okay. But getting real coffee, sometimes, how many of you are like coffee people, right? Like a good cup of coffee, you're like, okay, right? So the only time, true confessions of Melissa, right? The only time I've ever been written up at work was because, so this was this was in my previous life, I did payroll for 1,200 nurses. That's all I did. That was my whole job. No wonder I wanted to. Never mind, we won't go there, right? So I did payroll for 1,200 nurses, and we had somebody who forgot to clock in for like the third day in 2 weeks, and I was like, I got the email. It was like 7 o'clock in the morning. It was the first thing that I pulled up, opened the email, and I was like, right, send. Well, that was the only time I've been written up in my life. And literally, the action plan for behavior correction was Melissa will not respond to emails until after she's had her first cup of coffee and after 7:30 in the morning. That was literally in my written documentation, right? So we have to know what good coping skills and good self-care we can do to not have those precipitating factors influence our behavior without our permission, right? We have to give permission for those things to influence our behavior, because while we cannot choose what goes into our mind or what comes into our heart, we do choose what our behavior is as a response to those things, right? We can't choose what happens up here, like those initial things that come into our brain. We can choose if we dwell on it or if we act on it. You know, those are our choices. So finding something that works for you, right? You know, plan your next career move. I'm not planning, don't do that, right? We all want you here a Methodist, right? But there's all kinds of things, right? Laugh, say I love you, watch a funny movie, you know. There's a really funny video on Facebook this morning that was, this was lady, like, I don't know if you've seen it, the lady that was like trying to be a wine connoisseur. I don't know if you saw it. It was hilarious, right? So she's like, this is a vintage 2016, right? You know, I mean, like starting our day with something goofy as opposed to, hey, as opposed to so task-oriented. Something like that. Find what works for you to set yourself up for a good day, especially if you have a day or a morning like that little narrative that I read for you earlier, right? And the emotional support, right? Emotional support is really, really important. This is from the American Psychological Association, right? For people who have good emotional support versus people that have, who don't have good emotional support. 43% say stress has increased in the past year for people who don't have good emotional support. 26%, only 26% say that it has increased for people with that good emotional support. And nearly half of people, 46%, said they felt depressed or sad due to stress in the last month, people without good emotional support, whereas only a third of folks who had good emotional support were saying they were feeling depressed or sad because of stress. Having these positive people in our life that can uphold us, encourage us, do all of that is really, really important. Not just because it's a good idea, but because it affects us, affects even our physiology, right? Because when we are depressed, when we're sad, when we're stressed, those physiological things come out, which makes us less effective at the other things that we do in life, right? So we're gonna practice a little self-care here for a second, okay? So I want you to sit with your feet on the floor, okay? I want you to get in a relaxed and calm position. I want you to close your eyes if that's comfortable for you. If you take a nap, Sarah, don't even worry. I'll wake you up, okay? So I want you to just take a minute. I want you to take a deep breath in and breathe out. Take a deep breath in and breathe out. And do that just a couple of times. When you find your mind wandering to someplace else, come back to that breath. Breathe in and breathe out. Now start at the top of your head. Bring your awareness to your hair and your scalp. If there's any feeling of tension, try to release that. Let yourself just ease into the chair behind you. Feel the tension or relaxation behind your eyes. And just be aware of it. Again, if you start to attach a narrative or a story to whatever it is that you're thinking, whatever pops in your mind, go back to that breath. Go to your cheeks and your ears and your jaw. Let your jaw be soft. If your tongue is stuck on the roof of your mouth, drop your tongue from the top of your mouth. This will allow you deeper relaxation. Relax your neck. Let your shoulders drop. Let your shoulders drop down. No need to carry any weight right now. Feel how your shoulders or your back is against that chair, and allow that chair to support you. Let your arms relax. Let there be no tension in your hands. Let your chest and your belly just relax. You don't have to hold anything tight. Let your hips sink a little further into that chair. If there's any tension, take a deep breath in and breathe out, and try to let that tension go as you breathe out. Let your hips and your thighs just be fully supported by the chair underneath you. And let your knees be soft. You don't even have to keep your knees straight up. Just relax. Let your calves relax and your ankles. Feel the weight of your feet on the floor. And just take a moment to breathe again. Breathe in and breathe out. And when you're ready to open your eyes. That was about 3 minutes. It's something that any of you could do. You know, even if you're a bedside nurse, even if you're in an office, to take a couple of minutes to just breathe in and breathe out. By focusing yourself on your breath, it takes our mind out of like, this thing, this task I have to do, right? Because literally our brains cannot think about focusing on our breath and think about this work at the same time. If you put all of your breath in there, and it works if you have, say if you've got tension in your neck, as you breathe in, imagine that oxygen going directly to those muscles and then breathing out and that tension releasing. It gives us an opportunity to kind of get out of our brain, get off that hamster wheel, to be able to focus on ourselves, focus on our priorities, get ourselves right back to this moment. You know, in this moment, in this second, all I have to do is breathe. That's all I have to do. And that can give you an opportunity to be able to take care of yourself. Just one little skill. Have any of you guys done that before? Yeah? Does it work? You did it this morning. Good. Good. Yeah. It works as a pretty good reset, right? And like a 3-minute nap at work that totally seems appropriate, right? You can just say, Melissa said I have to do self-care, right? So just blame it on me, right? So our goal is to make sure that you guys have what you need, right? You have what you need to take care of yourself in order to be able to take care of our patients. Because that's our goal. At the end of the day, we all have the same goal. Just life and humans and irritations and work and stuff get in the way, right? So that's all I really have for you today. Do you have any questions? Do you have any thoughts? Do you have any stories? Anything you want to share? We're done a little bit early. All right. Well, thank you. I hope you all continue to take some time to do some self-reflection, you know, especially if you find yourself needing a timeout or feeling yourself escalating. Make sure you take that time out. Take that time to breathe, to do some things, to say, what is actually going on with me today so that I don't become an irritating factor to somebody else and my stuff doesn't get projected on those patients. So, because that's our goal, right? Thanks, guys. Have a good day.